The government's plan to implement the diagnosis-related groups (DRG) system across both public and private healthcare sectors in Malaysia marks a major shift in how we finance and manage health services. The DRG model, widely used in countries like Germany and Australia, is designed to improve efficiency by standardizing payments based on diagnoses, rather than length of stay or individual services. At first glance, it seems like a rational move toward better cost control and transparency. But is Malaysia truly ready for it? In theory, DRG promises several benefits. It offers a fairer reimbursement model that ties payments to the complexity and type of care rather than how many tests or procedures are done. This could help curb unnecessary services and promote better resource management. For the public sector, where demand is high and resources are often stretched, DRG may create the incentive to treat patients more efficiently. In the private sector, it can introduce much-needed price transparency and make costs more predictable for insurers and patients alike. However, implementing DRG is far from straightforward. The system relies heavily on accurate and detailed coding of diagnoses and procedures. Malaysia's current infrastructure, especially in the public sector, may not yet be equipped for this. Many hospitals still operate on paper-based systems or fragmented digital records. Coders and clinicians will require training to ensure accuracy. Any errors or inconsistencies could lead to disputes in reimbursement and, more worryingly, gaps in patient care. Another major concern is the potential unintended consequence of cherry-picking. In a DRG model, hospitals may become reluctant to treat complex or high-risk patients whose care costs exceed the standard payment. This could widen the gap in access between well-funded urban centers and under-resourced rural hospitals. Without proper safeguards, vulnerable patients might find themselves caught in the cracks. Malaysia's dual healthcare system adds another layer of complexity. While the public sector serves the majority of the population at subsidized rates, the private sector operates on a fee-for-service model. Bridging these two worlds under a unified DRG framework will be a daunting task. Will private hospitals accept lower reimbursements under DRG? How will costs be benchmarked across sectors with vastly different operating models? And who will oversee compliance and quality? For DRG to succeed, the groundwork must be laid properly. This includes investing in robust health information systems, building a national coding infrastructure, training healthcare workers, and piloting the model before going nationwide. Stakeholder engagement is critical. Doctors, insurers, hospital administrators, and patients must all understand the new system and how it affects them. Transparency and oversight mechanisms must also be strengthened. Without clear accountability, DRG could become a bureaucratic burden rather than a driver of reform. DRG can work in Malaysia, but only if implemented thoughtfully and gradually. A rush rollout could cause confusion, distort care delivery, and erode public trust. It's encouraging that the government is looking at ways to improve healthcare efficiency and sustainability, but we must be cautious not to import a system without adapting it to local realities. Healthcare reform is never easy. DRG could be a valuable tool in Malaysia's long-term strategy, but it is not a silver bullet. We need to be realistic, vigilant, and most importantly, patient with the process.